Okay, you guys, I think so. My talk is centered on acquired aplastic anemia, and so thanks for hanging in there, and happy to take questions kind of at the end or as I go too. So I'm going to talk first just about establishing the diagnosis, and I had some nice conversations at lunch that I realized I think some terminology we could do a little bit better in defining for you guys, and I hope I do that here in the establish the diagnosis, and then I'll go through treatments. So when we start with the diagnosis, many of you have undergone this procedure, a bone marrow biopsy. And so we kind of go in back where you put your hands on your hip. It's the bone is called your posterior iliac crest. And we go in with a needle that takes a piece of the bone. And then we also go in with a needle that we suck out the liquid part of the bone. And we call that a biopsy and an aspirate. And that just kind of shows what we're doing on your backside when you might not have seen it. The biopsy looks like this, and the needle is a hollow bore needle. We kind of push that biopsy down, it gets embedded, and we can look at it under a microscope. And the liquid part is sucked up, and we smear that on a slide, and we can look at the cells. And the reason we do it both ways is it kind of gives us two pieces of information. You can look at the biopsy and say, how much of the space is occupied by cells? And you can look at the aspirate and say, what do the individual cells look like? And so here is a biopsy. So this is a chunk of bone. And this is that biopsy under the microscope. And so what you see by these swaths of pink, that's bone. The space in between these pieces of bone is the marrow. These are your blood cells. And the areas that you see as white are fat cells. So they just don't stain with the stain. So this is a mix of cells that will grow into your red cells, that'll grow into your white cells, and will go into your platelets. The aspirate is the liquid part, and that lets us see these cells, but individually. And so here is just a look again at that aspirate, and these are those cells, and it's not important, but kind of the bluer ones are the red cells. The hemoglobin in those developing cells gives the very dark blue color to them. And these are the neutrophils, the white cells that are maturing along. So what we have in states where I'll use the term just blankly called hypocellular, that just means that the bone marrow, when we look at it under the microscope, we don't see as much cellularity. We don't see as much of those cells that make blood cells. So again, here's a normal looking biopsy, a normal looking aspirate. And this is an individual, one of my patients who had acquired aplastic anemia. And what you see is, gosh, I can see those bony pieces, but in between there, Dr. Keel, I don't see any of the blood cells that are going to grow into the white cells, the red cells, and the platelets. And similarly, if we look at the aspirate, the liquid part, you still see the kind of what I call the framework or the architecture of the bone marrow, but you don't see the stuff that's on that architecture. So the analogy might be you have a building with a scaffolding. The painters are on the outside of the building, and if all of the scaffolding is occupied by painters painting the building, that's 100% cellularity. And if you had a low cellularity, maybe you only have one person painting on that scaffolding. And so again, the term hypocellularity is just a description. It's just what the pathologist looks at under the microscope. And another term that's used, and we drop these kind of all the time. So I think sometimes people think we're using it to define a specific diagnosis. The term aplastic can be used to just mean hypocellular. So you can say the person had an aplastic marrow, and all we're saying is that's what it looked like under the microscope. Separately, there's a term that we drop called acquired aplastic anemia, and that's a specific diagnosis, and that's what we're going to talk about in this talk. But again, there are different reasons that you can have a hypocellular or aplastic marrow, one of them being acquired aplastic anemia. So when a person comes to our clinic, they have low blood counts. We say, gosh, what's going on? We're going to look in the marrow and we see a hypocellular or an aplastic marrow. And there's kind of broadly two reasons why you might see that. It might be something that happened to them during their lifetime, an acquired cause. And the acquired causes that cause a hypocellular marrow are acquired aplastic anemia, a specific diagnosis, hypocellular MDS, a specific diagnosis, or sometimes it can be due to drugs or toxins that a person's been exposed to. Alternatively, the other reason that people can have a low cellular or hypocellular marrow are the things I talked about earlier. And I just put that here for completeness. There are some cases where that low cellularity is due to an inherited reason that they developed that. And so to kind of hammer that in, I wanted you guys to just see, these are 3 of my patients' bone marrow biopsies, and they're all about the same age. The cellularity of a person's marrow is a little function of your age. So roughly it's 100 minus your age. So if you're 20 years old, you would expect the amount of cellularity between these swaths of bone to be 100 minus 20, it's 80. So you would expect it to be 80% here. So in this case, these were 3 different individuals about the same age that I saw, and they all actually had different diagnoses. This person had acquired aplastic anemia. This person ended up having something called hypocellular MDS. And this was a patient that I follow who has an inherited bone marrow failure syndrome. And these specific diagnoses came out of the additional testing that's done on the bone marrow. This is just making the point that the visual appearance of the marrow doesn't tell you everything. You need all those molecular studies and the other things. So acquired aplastic anemia, that's what this talk is centered on. There's a biphasic distribution. Individuals can either present at a younger age, typically under 20 years of age, or the second kind of peak in the incidence of this disease that we see in people is later in life. It's presumed to be caused by an immunologic destruction of the stem cells. And so it's an immune attack, something called your T cells, that are targeting the stem cells that make your white cells, your red cells, and your platelets. And there's lots of studies that kind of are going at that mechanistically, kind of some interesting science. But to kind of summarize it, think of it as the immune system is targeting your own stem cell and destroying it. And that leads to kind of 2 things that are contributing. It's destroying stem cells, so you have a stem cell deficiency. The number of stem cells is reduced, but you also have an immune system that's dysregulated, that's attacking there. And I kind of make those 2 distinctions because when we give therapy, for example, the horse ATG, cyclosporin, and L-trombopag that some of you may have received, they're kind of targeting 2 things. The L-trombopag is a growth factor because of the stem cell deficiency to increase the number of stem cells. And the cyclosporin is suppressing that immune system. So we're kind of hitting both reasons of what attacked the bone marrow that resulted in that low cellularity. And then you might just hear, we also drop this term around. You have severe acquired aplastic anemia, or you have moderate acquired aplastic anemia. And those are just definitional, you guys. And I kind of think of them broadly as there's a classic definition of severity and there's a practical definition. And the classical definition, don't get too hung up about it. It came from a paper in 1976. I was just 5 years old then. And so, that's a long time ago that we used a classification system. And when I point out that it's a long time ago, sometimes you want to think more kind of in the current times and what I call a practical definition, which is if you don't meet exactly all these requirements, but you're transfusion dependent, you have a problem. You still need therapy. And so the practical definition that I use is you require red cell transfusions, you require platelet transfusions, or your neutrophil count, the cells that fight infection, are low enough that you're at risk for developing infection. And then again, this committas criteria is just kind of, you have this and this, we call it that. So I won't go into detail here, but this is just to highlight that we went over that the visual appearance of the marrow can tell you the cellularity is low, but when you establish a specific diagnosis, you need more kind of more sophisticated testing to actually say, is this acquired aplastic anemia? And earlier I talked with you guys about 2 useful things that help us to say this is an acquired aplastic anemia. This is an immune aplastic anemia, as opposed to those inherited disorders, was the presence of that PNH clone and also something called copy neutral loss of heterozygosity. Those were 2 things that I talked about earlier. So think of those as just 2 diagnostic hints that help us tell it's acquired aplastic anemia. This is to hammer out that PNH. I just put it in one more time. These are detectable. You can find those populations of cells in about 50% of patients that have acquired aplastic anemia. So it doesn't mean you don't have acquired aplastic anemia if it's not present, but if it is present, it's quite specific for a diagnosis of acquired aplastic anemia, or rarely this thing called hypoplastic MDS. The other thing that we've talked a lot about here, you guys, you saw it on many slides when we were talking about prognosis in MDS, the use of that molecular markers, the molecular profile of patients' MDS. In the context of acquired aplastic anemia, people have asked, gosh, would the presence of mutations be helpful in terms of distinguishing acquired aplastic anemia from MDS? Would that help diagnostically to say, yep, we're for sure working with acquired aplastic anemia here? And I would say that that hasn't really panned out, that the mutational spectrum you can see in acquired aplastic anemia has some overlap with this entity called hypoplastic MDS. And so I would say about 30% of the time in acquired aplastic anemia, you find some mutations. You guys, the specifics of the mutations matter. And so I know some of my patients in the audience are saying, oh gosh, what about my mutations? There are certain mutations that are concerning that tell us this disease has changed over time. What I will say is these mutations, it does appear that they can be prognostically helpful in certain scenarios. So that's kind of a long story to say, at our center, we standardly send these mutation panels in all our patients, but I think they're less diagnostically helpful in this setting than they are, for example, MDS. So here I just wanted to show one other thing, because this comes up a lot in our patients that are diagnosed with acquired aplastic anemia. I see this referral a lot, and I always try to explain it to the patient. And so I just thought I'd explain it to you guys here, which is sometimes patients come to me and there's this question of, do they have acquired aplastic anemia? And it's because they have really low blood counts, but the bone marrow aspirate biopsy they got at the outside setting, it didn't look all that empty. It didn't look as hypocellular as the pictures we looked at earlier. And oftentimes that's because the cellularity is patchy, you guys. Nobody wants to have this done to them, but if we poked you a gazillion times in the back and you laid them down on the smear and looked at them, there's variability across the bone in how cellular something is. And so you could, the peripheral blood counts really are the best average of what the cellularity is, because that's what the bone marrow is making. So here was one of my patients, and you can see that this part of the person's bone marrow looks like an acquired aplastic anemia, but deeper, this is where the residual amount of blood cells this patient was making were coming from. And his first marrow just happened to hit all of this. And so there was a little bit of diagnostic uncertainty initially, just because of the region that we hit in the person's bone marrow. And when we repeated it, we could see very clearly that the patient had areas that were hypocellular. So again, the take home here is the cellularity can be patchy, and just sometimes upfront the marrow, we have to kind of make sure we're dealing with what we think we're dealing. So what about the treatments? We talked broadly just about the diagnosis of acquired aplastic anemia, that it was an immune-mediated process. Up front, there's kind of a broad treatment decision, is whether a person proceeds to immune suppressive therapy or transplant. And I'm going to first just talk about immune suppressive therapy and what the outcomes look like for that. And the standard immune suppressive therapy, when I use that term, I'm talking about horse ATG, cyclosporin, in a drug called eltrombopag. And this is this was developed initially at the NIH as kind of a single center that developed this protocol. And now there's been a randomized multi-center study, the RACE trial, that's the data that I'm showing here, of giving patients immunosuppressive therapy, which has been the standard for a long time, of horse ATG, cyclosporin, with or without the addition of this drug, Promacta, or eltrombopag. And eltrombopag is a drug that was developed for an entirely different reason. It was developed for a disease called ITP, but its function, you have receptors on your stem cells that this particular drug binds to. And so in the context of acquired aplastic anemia, it's essentially a growth factor. And so this study was looking at the addition of eltrombopag to standard immune suppressive therapy. And what you can see is that the complete response rate at 6 months was increased by the addition of giving L-Trombopag. And the way that these studies were done is typically patients are given horse ATG for 4 days. They come into the hospital, get that as an infusion. The cyclosporin is continued generally at therapeutic doses where we're monitoring the blood level for about a year. That's then reduced and continued generally until year 2. And the L-Trombopag is given someplace between 3 and 6 months, depending on how a person responds. Okay, hold on. And what you can also see is the benefit of this L-Trombopag, and I think this, in my mind, is kind of the biggest benefit of it. What it does is it improves people's blood counts faster. And so the time that they require platelet transfusions is reduced, the time that they require red cell transfusions is reduced. And then potentially the most important, because it's the riskiest, the neutrophil count comes up fastest. So patients who have severe low white blood cell counts are at risk for infections. And so if you can bring their white count up a month quicker, that's a big deal. That means their infectious risk goes down. And then I just put here this was also studied in a phase 1/2 study at the NIH, and the complete response rates and overall response rates when you added that L-Trombopag looked similar to the randomized study. What I'll say is people have done a subset analysis of the NIH data to ask, should we be giving this L-Trombopag to our pediatric patients? Was the benefit, did the benefit hold in that population? And the reason people wanted to look closely is one of the concerns was, is there a downside to adding a growth factor to the cyclosporin in the ATG? And the concern was, if you give a growth factor, is there any risk that you might drive leukemia development more? And so that's why people have been very thoughtful about the use of this drug. But in any case, I'll come back. That has not been shown. We have not seen that there's a higher leukemia incidence with the addition of L-Trombopag. But this benefit in terms of the overall response rate and the complete response rate at 6 months didn't seem to hold in the pediatric population. So our colleagues at Seattle Children's don't standardly give L-Trombopag. We're doing that on the adult side. So what's the kind of downsides of giving somebody immune suppressive therapy upfront? What's going to happen over time? And I think that the big things are a couple. One is the relapse risk, and the relapse is very loosely defined, you guys. It generally means that a person who had a response now requires transfusions again, or that their neutrophil count has dropped to a level that's not safe. They need therapy again. And the first data the first reference that I put here was it is the longest term data that we have without the addition of L-Trombopag. So this is long-term data using horse ATG and cyclosporin. And about a third, there's relapse in about a third of responders. So it's pretty common that people drop their counts again. If you look at the data since the addition of L-Trombopag, without L-Trombopag or with L-Trombopag, I'll come back to why I divide this a little, is only about 30% of patients that are treated with horse ATG and cyclosporin, when you look way down the line, are completely off medication or off cyclosporin and L-Trombopag. That means the majority of patients, about 70%, require some amount of immune suppressive therapy. And that's similar with the addition of the L-Trombopag, you guys. It doesn't change that long-term requirement for ongoing therapy. So lots of people ask me, and we talked a little bit about this at lunch, is, gosh, I'm on cyclosporin and L-Trombopag, Dr. Keel, what do you think is going to happen to me over time? And I'd say most people need to continue on that at some dose long-term. That doesn't mean it has to be a high dose. Lots of people can be on one or the other or both at low doses that are tolerable. And what was seen in the NIH data when they looked far out from the study that added L-Trombopag was that the relapses happened at the 2 time points when you might have predicted the relapses would happen. So let me say that a little more clearly. The L-Trombopag was given for 6 months, then stopped, and the cyclosporin was given to a year at therapeutic doses and then dropped over the next year. So people stayed on it for about 2 years. And the 2 time points in that study where you saw people have relapse is shown here. The first was this is the beginning of the study, you guys. And at 6 months, when people stopped the L-trombopog, you can see that the probability of relapse bumps up. That when you stop the growth factor, a reasonable percentage of patients had relapse of their disease. And then the other time point where these where this curve starts to rise again is at 2 years. And that's when the cyclosporin was dropped. And so that tells us a little bit about the person's physiology of their disease. Probably this first relapse, the early relapse when you stop L-trombopog, remember that's a growth factor. That's to expand the number of stem cells you have. And so there's some population of people that you can't expand their stem cells enough that they grow in numbers to repopulate their marrow persistently for the whole time. They need that growth factor ongoing. And then some people do okay. You increase their stem cell number enough with the L-trombopog, but they're dependent on the immune component being addressed by the cyclosporin. So that's kind of what I come to expect when I put a patient on immune suppressive therapy with L-trombopog. The other thing that I always point out to patients up front when I meet them is patients that have severe acquired aplastic anemia have a risk that their disease changes over their lifetime. And that lifetime risk of developing MDS or leukemia is estimated in a number of studies now to be about 10 to 15% of patients. That's a lifetime risk, you guys. And so that means it happens many years later, but that's a reasonable risk. And that risk is not changed by giving them immune suppressive therapy or L-trombopog. That's a risk that is present for those patients. The only thing that addresses that risk, that eliminates that risk of developing leukemia in our severe aplastics that we know about right now, is transplant. For the patients that have upfront transplant, that risk goes away. And then I'll just say there is a study that's not open here, but is ongoing at other centers that's saying, gosh, could we do something about these patients who relapse when we stop the cyclosporin down the line? And so people are using another immune suppressive drug, a drug that's given by mouth called sirolimus, and asking, might that give people a more durable response? So again, the downsides of immunosuppression plus L-trombopog, I think one is relapses are common and that most patients will require some dose of cyclosporin and L-trombopog. I don't want to be pessimistic about that, you guys. Lots of people are on a low dose of cyclosporin or L-trombopog and they do just fine. But some patients might say, that's not something I want to have for myself. And so I always let them know kind of what to expect over time. The other is these drugs can have toxicities. And the big one for cyclosporin, there can be some cosmetic things. It can cause hair growth. And for some people that can be on the face and they might not like that. It can also contribute to renal dysfunction. So kidney dysfunction long-term is a concern. And then cyclosporin, some people just don't like the way they feel on it. And so there can be implications for quality of life over time. And then the other one I already highlighted is that this approach, a non-transplant approach for acquired aplastic anemia, severe acquired aplastic anemia, doesn't address the risk of developing leukemia. So then let's kind of step back and just talk a little bit about transplant as the alternative upfront therapy for patients that present with acquired aplastic anemia. And what I'm just starting with is kind of historical data, you guys. This comes from the European Society for Blood and Marrow Transplantation. And you can see the dates of these are pretty old. This is 2001 to 2010. And I show this for two reasons. One is the next slides are going to say we've improved, we're doing better. But also to highlight that the response to therapy, whether it's immune suppressive therapy or a transplant from a matched sibling or a transplant from an unrelated donor who is matched, the outcomes are kind of loosely age dependent, but that outcomes are best in younger people that present with acquired aplastic anemia. I'd be a little bit careful on this, you guys, because the older people are a mix of people, that some are healthier than others. And so we certainly have outcomes in older patients that are very, very excellent because they're fitter, they have less comorbidities. And then the second thing that I'll point out is that even in historical data, if you look at transplant outcomes from a matched sibling, they look very good. The outcomes for a person over 40 in the historical data, kind of 2-year overall survival for an unrelated donor transplant, was on the order of about 40% to 50% 2-year. And we've done much better. It's improved. And so this is more current data, 2010 to 2018, looking at an upfront matched unrelated donor transplant or a mismatched unrelated donor transplant. And what you can see is that the overall survival at 2 years is on the order of 75%. So we've already improved on those outcomes quite a bit. So what I'll say is something that has emerged in the last number of years. Folks are interested in thinking about how can we improve transplant outcomes. And one approach that's happened is the introduction of something called post-transplant cyclophosphamide. So think of it as an approach to transplant that addresses, potentially reduces, not potentially, it does reduce the risk of graft failure and also of GVHD. And so this is looking at unrelated donor allo transplants given post-transplant Cytoxan. It's just a single series, but it was one of the earliest studies, and so that's why I show it here. And these were patients that had been previously treated, so you might even expect their outcomes to be a little worse because they didn't have an upfront transplant. And you can see that their 2-year overall survival really looked great, 88%. So there are lots of changes. There have been changes in our approach to transplant that have improved outcome. And one of those is the introduction of this post-transplant cyclophosphamide in some patients. So another thing that's emerged is, well, a challenge in transplant, and we saw some of that data early, is can we find a suitable donor for all patients? And so again, if you have a sibling, there's a 25% chance that your sibling could be a match. But otherwise, we would have to move to either an unrelated donor or potentially one of these haploidentical donors, a parent or a child. And so people have asked, well, what about the outcomes of using a haploidentical transplant for acquired aplastic anemia? And this was a study that the CTN had done in individuals with severe acquired aplastic anemia that were relapsed or refractory disease who didn't have a matched sibling. So these were folks that didn't have a suitable donor, and they were treated with an upfront haploidentical transplant with a post-transplant Cy approach. And again, what I want to highlight is these patients did really well. Their overall survivals looked quite good. Their GVHD risk was reasonable. So people have now asked, well, if we see that kind of outcome in relapsed refractory patients, is there a role for an upfront haploidentical transplant for patients where you don't have an HLA matched SIB? Or even there can be time constraints in organizing a unrelated donor transplant. And so another push for thinking about haplotransplants is typically those donors are more readily available. It might be your parent or your child as opposed to mobilizing an unrelated donor. And so this is just a single center study. And so we have to make sure that we see this data replicated in broader multi-center trials. But this was a single center trial looking at upfront haplotransplant and again, encouraging outcomes. So just to highlight kind of some things that are very imminently happening, this is a study that is opening here soon. It's opening at a number of centers. This is actually over at the pediatric site at Seattle Children's site. And this is asking in a person that has newly diagnosed severe acquired aplastic anemia, where they do not have a suitable HLA matched sibling. That would always be kind of the first choice for transplant. And it looks like they have an available unrelated donor by a World Book search. So the organization that helps us to look for unrelated donors has committed on this. They've already done a pilot study. Can we rapidly HLA type patients, figure out what their HLA type is, sort of say, okay, they don't have a matched SIB. If we look in a World Book, do we think we're going to find an unrelated donor quickly? And if they do, they could be eligible for this study that would randomize them to an upfront matched unrelated donor versus immune suppressive therapy in folks that are under 25 years of age. And so we'll see how that goes. It's directly asking that question of which is a better outcome. And then a second study that's also getting at this question of what's the optimal upfront therapy when we have these other potentially suitable donor approaches. This is another CTN study that's planned that's asking, what about an upfront matched unrelated donor or a mismatched unrelated donor versus a haplo? Should you go with an unrelated donor or should you go with a haplo in a severe acquired aplastic anemia? And this is eligible for adults over 25 years of age, again, that don't have an HLA matched related donor. And we'll have to see what the outcome of that data looks like. Again, asking that very direct question, which is the best approach. So I put this up here, you guys, and not to be prescriptive, because there is individual decision-making that happens on what's optimal for a person in terms of their fitness, whether they have a suitable donor that's available. And different centers have different expertise, say with haploidentical transplants, and they prioritize those differently right now. I think the results of the studies that I showed before, those are really going to be helpful in saying, what is the best approach? So this is kind of an outline of a broad way to start thinking about this. So I first ask, is the person a transplant candidate? And I would say, I think what's emerging is age to an extent. I don't want to say completely, but age to an extent isn't an exclusion for transplant eligibility. And so kind of classically in the old days, oftentimes there would be slides that said, if you're under 40 or you're over 40, that was the cutoff of who we would transplant. And that's not the case anymore. There are people who are 50, 55, even 60 that are very fit and can go to transplant. And so I deliberately left that a little vague. Is the person transplant eligible in terms of their fitness? And does it look like we're going to find a donor? And so first we ask, do they have if they're not transplant eligible, we go ahead with immunosuppression and L-Trombopag. If they're transplant eligible, do they have a matched SIB? We still prioritize a matched HLA sibling transplant. If there's no HLA matched SIB, then this gets a little bit more complicated. And here at our center, we ask, is there a matched unrelated donor available? And if there is a matched unrelated donor available, again, this is a person who's a transplant candidate, and that unrelated donor, we can mobilize quickly, you guys. And sometimes we can't. Looks like there's only one person out there that might be a match, and you're not going to have that person available. Then we think about if they're under 25, this transit study that I mentioned earlier is opening at Children's. That's going to ask that question of an unrelated donor BMT versus immunosuppressive therapy. If they're over 25, this study will be opening, asking about a matched upfront versus a haplo. We'd consider a matched unrelated donor. And there are some patients where we still say immunosuppressive therapy might be the appropriate consideration, or an unrelated donor. So I talked a lot about upfront treatment for acquired aplastic anemia, this kind of decision between immune suppressive therapy or upfront transplant. But we also have lots of patients that we also see for relapsed or refractory disease. And so just to make sure we're all on the same page, I use the word relapsed to say recurrence of severe disease, that you need transfusions or the neutrophil count is low enough that we need to do something about it after an initial response to therapy. And the term refractory to mean you haven't responded to the immune suppressive therapy and L-Trombopag. And generally, you guys, I put this a little loose, we kind of assess that response at about 3 months. If people are starting to come up in their counts, we might say, hey, hold on, we're seeing a response. Let's assess that at 6 months. So that's what I use for relapsed and refractory. And I'd say first, I always repeat the marrow in that context, you guys. And the reason I repeat the marrow at that juncture is because one, we talked earlier about that risk of the development of AML or MDS. You want to know if this disease has changed, or is there any possibility the diagnosis up front wasn't correct? So I always look again in my patients that have relapsed or refractory disease. And then I ask pretty much the same question I asked before is the person a transplant candidate? And if they are a transplant candidate and there's a suitable donor, we prioritize moving towards transplant in those patients. And if they're not, We really don't have a standard of care, you guys. There are a number of different things that we try, and I'm happy to talk to folks about that kind of on the side. I didn't put all that here, but there isn't a standard of care in the community about what's the optimal therapy. And I'll stop there.
Okay. Any questions for Dr. Keel? Yes, I'll give you. Well, there's people that are listening virtually.
I couldn't help but notice throughout the day that there were several mentions as to the age of donors and that age being
Oh.
young. And I've participated in a lot of bone marrow drives. I've convinced people to get in to the registry. Are older folks not necessarily ever going to be a donor, and are they excluded, and really at what age?
Oh, so I love your question. So so I make sure it's clear for here. We were talking about age of the person to proceed to transplant. You're asking a little bit different question, which is what are the characteristics that allow a person to be a transplant donor? And how do we prioritize donor selection? And Bart, I wonder if I can punt that one to you as a transplanter.
Sure. Well, our preference is to use a matched family member, typically a sibling, when possible. We currently do not type siblings or family members over age 65. So that's because of what Dr. Caraway was mentioning, CHIP. And as we age, the possibility of getting a CHIP increases. And we consider that to some extent to potentially be a pre-malignant condition. So we don't want to use older donors for this risk of CHIP. And the other issue is that it's harder to mobilize older donors. We have two ways of getting stem cells. One way is by taking a donor directly to an operating room and removing stem cells directly from their iliac crest. For aplastic anemia, that is our preferred way of getting donor cells because you get a lower risk of something called graft versus host disease. Now, for other diseases like MDS, we want to use peripheral blood stem cells. But whether you're using marrow component, bone marrow, or peripheral blood transplant, it's more difficult to get the stem cells from someone as they age. So stem cell availability and the potential risk of inducing a second malignancy is why we use 65. There's other things that we consider, health issues. So we have screening questionnaires for family members. Unrelated donors come through registries, but we do not collect people into our registry, the National Marrow Donor Program, if they're over age 65 for sure. And I believe the cutoff could actually be 50 for donation. Did that answer your question? Okay. Other questions for Dr. Keel?